So I had to do the last couple of slides again because of technical issues. I'm using a Windows-based computer, unfortunately. Type. So I think the program or the software PowerPoint does not like annotation, so I'm gonna avoid annotation so we don't get into trouble. This is part 2, and we start from where we stopped the last time. We were talking about growth hormone deficiency, and the gold standard to test growth hormone deficiency is to use the insulin tolerance test. As shown here on the graph, if you look at the top left part where the insulin injection is given, and the circles are the glucose levels, so they decline sharply after the insulin injection. And if you look at the bottom left corner, the triangle represents the growth hormone level and the square represents the cortisol level, and both of those hormones after 30 minutes start to rise following the reduction in glucose level, and they reach a peak at about 60 minutes following the insulin administration. So that is what we typically see in normal response if the growth hormone axis and the cortisol axis were both normal. However, in patients with growth hormone deficiency, you don't see that rise, which is depicted in this diagram. There are other tests that we can use to diagnose growth hormone deficiency, including glucagon stimulation test and GHRH arginine tests. What we typically do most of the time is either GHRH arginine test or the insulin tolerance. Growth hormone deficiency, if it was diagnosed, it's treated with growth hormone replacement. Limited use, I would say, in patients with in patients with pituitary tumors. Among all the patients that I have in my clinic, I have only one person who requested to be treated with growth hormone to see if he feels better on it or not, because it's the benefits are difficult to pinpoint. Mainly improvement in bone mineralization, exercise capacity and muscle mass, and it could reduce a bit body fat and improves quality of life. However, treatment is administered through daily subcutaneous injections, which have to be kept in room temperature or refrigerated when not in use, and it's pretty expensive. And we typically monitor the response to therapy by following the IGF-1 level, and we want to keep it in the normal range for the age. Now, it's important not to give growth hormone therapy for people who have a history of active cancer, just like we don't give testosterone to patients with active prostate cancer. It's not that testosterone causes prostate cancer, but it just fuels the cancer if it was present. Therefore, we do monitor PSA levels in patients who are on treatment with testosterone therapy. PSA stands for prostate-specific antigen, which is a prostate cancer marker. And also we do digital examination routinely on these patients. Moving on to diabetes insipidus. This picture, actually, I find it important to keep in mind. Patients with true diabetes insipidus are thirsty almost all the time, and they go to the bathroom very frequently to pass urine. So it's not unusual for a patient with true diabetes insipidus sitting in front of you in the clinic to have a bottle of water and to ask for excuse every couple of minutes or so to go to the bathroom, maybe every 20 minutes or 30 minutes to go to the bathroom and pass urine. So those patients do not hide themselves if the case was a true and clear case of diabetes insipidus. However, we do get partial or mild cases which might require further investigation. Characteristically, the posterior lobe of the pituitary lacks the bright spot which we see in normal individuals, and here the arrow shows the posterior lobe, which is dark in color, indicating that this patient most likely has diabetes insipidus. So it results from deficiency of antidiuretic hormone. We mainly encounter diabetes insipidus in two settings: after pituitary surgery, which is considered a complication, but most of the time it's transient and resolves spontaneously, a couple of days after surgery. However, in some patients it might persist, and the patient would require long-term treatment with desmopressin. The second situation where we typically expect and see diabetes insipidus is in cases of craniopharyngioma, lymphocytic hypophysitis, and pituitary apoplexy. And remember, microadenomas per se do not present with diabetes insipidus except rarely, so that's something to keep in mind. How do you diagnose diabetes insipidus? The typical symptoms of polyuria and polydipsia, and definition of polyuria is putting out urine over 3 liters per day. Remember, you have to distinguish this from primary polydipsia, which is a psychological issue where patients like to drink a lot of water. In the hospital, passing urine more than 250 cc's per hour for several hours is considered high and should alert the physician to the possibility of having diabetes insipidus. Now, in general, the labs will show dilute urine, low urine osmolality, but in cases that require proper investigation, the go-to test is the water deprivation test, and the patient needs to be admitted to the hospital to perform that test. We ask them to stop drinking, and then we measure their urine osmolality, which typically continues to be low, and they start to have rise in serum osmolality if they refrain from drinking water, along with hypernatremia and weight loss. So there's a certain protocol that we follow for these patients to conclude that they do or do not have diabetes insipidus. Patients with primary polydipsia, of course, would continue to have would start with dilute urine, but over time they would start concentrating, and they would never have issues with serum osmolality or they would never have issues with high serum osmolality or hypernatremia if you deprive them from water. How do you treat diabetes insipidus? Well, mainly we use desmopressin, either administered as a nasal spray or sublingual tablets, and in both formulations the drug needs to be given twice daily. So to summarize the medical therapy for pituitary adenomas, if the patient has central adrenal insufficiency, we treat those patients with glucocorticoids, and there is no need for mineralocorticoids. If the patient has hypothyroidism, we treat them with levothyroxine. Patients who have prolactin deficiency do not need to be treated. Patients who have LH and FSH deficiency would be treated with estradiol and progesterone in women and testosterone in men. However, individuals who seek fertility need to be treated with HCG and FSH, and that is the case for both men and women. Growth hormone deficiency can be treated with recombinant growth hormone injections, and finally, diabetes insipidus needs to be treated with desmopressin, as we mentioned. Now, we covered the medical treatment for hormone deficiencies. How about surgery? When is surgery indicated? Well, if somebody presents with optic chiasm compression, then that's an indication for surgery, and they need to undergo transsphenoidal adenomectomy. Severe headache is not usually an indication, because 50% of patients operated for headache who have pituitary adenomas improve post-operatively, and 50% do not improve after surgery. So it's not a strong indication, but sometimes we do it in symptomatic patients. Apoplexy, of course, needs to be operated on to decompress the sellar area, and if the tumor recurs after initial surgery, then the patient might require other surgery. The histological sample is sent to the pathologist for review, and they typically stain it with immunohistochemistry. For example, here the prolactin stain is positive on the left image, where you see the orange dye. On the right hand side is another stain which is called Ki67, and it's a proliferative marker. The higher the percentage of Ki67 stain, the higher proliferative rate for those cells in the pituitary, and of course the higher number means that this is an atypical adenoma which requires closer follow-up. Now, radiation therapy also has a role in those patients. when do we choose to send patients for radiation therapy? If the tumor regrows after surgery, that's one indication, or if the tumor cannot be resected fully. And also remember that in secretory pituitary adenomas, if we're unable to control the hyper or the elevated hormone secretion by surgery and by medication, we also revert to radiation therapy. There are two types, the conventional type of radiation therapy and the gamma knife. Gamma knife is given in such fashion that you see here in the diagram, where a concentrated dose of radiation is focused on a very small point to affected in a great way, and it's usually given in one session. The conventional radiation therapy is given over several sessions, or what we call fractionations. Pituitary apoplexy is a condition which is considered life-threatening, and it's acute. What happens is there is infarction of the pituitary gland or the adenoma. So it can happen in a pituitary gland, and the classic example is Sheehan syndrome, post-obstetric hemorrhage. But more in our field, we see apoplexy in patients who already have pituitary adenomas, typically macroadenomas. They tend to have the possibility of bleeding, or what we call apoplexy. So how do these people present? Severe headache, nausea and vomiting. And the severity of headache is not something to be taken lightly. It's really, really severe type of headache. Visual field defect can also be seen with cranial nerve palsies and altered mental status. Here you can see on those two diagrams, let's take the right one. You can see a fluid level where the hypointense is precipitated in the right hand side, and left hand side the hyperintense, which is the whiter, is the superficial. Remember, this is a patient who's lying on their back when the MRI was taken. So treatment is immediate surgery for decompression, and those patients need to be followed up by repeating their hormone levels, because they may have hormonal deficiencies following apoplexy or surgery that they did not have preoperatively. There are some reported cases of apoplexy occurring in secretory pituitary adenomas resulting in cure of the condition. Again, those are case reports and very rare. The next condition we want to talk about is lymphocytic hypophysitis. It's inflammation of the pituitary. Rare condition, occurs most frequently in pregnancy, in women of course, but it can be seen in men and out of pregnancy. How do these people present? Usually severe headache. Hormonal deficiency might include ACTH and antidiuretic hormones, so they present also with diabetes insipidus. They're treated with steroids to reduce the inflammatory response. Surgery should not be done in those cases because you're not going to be able to remove inflammatory cells. Basically, it's not a tumor, it's an inflammation with lymphocytic infiltration. Other stellar tumors that are noteworthy include craniopharyngiomas, which originate from Rathke's pouch. They're more common in children. They're cystic and solid in consistency, and they often require surgery, often repeatedly, because they tend to regrow after the initial surgery. And those also might require ring therapy if the tumor regrows. Finally, I want to touch on another type of cellular tumor which we see not infrequently, which is meningiomas. They tend to grow in the cellular area above it or below it, and they affect the pituitary hormones just like the adenoma or the typical adenomas, and the treatment is usually surgical. Of course, hormone replacement might be indicated if it was confirmed by testing. So that's it, the second part of the second lecture, and we're gonna take more questions when in a couple of days when we give that lecture. Thank you very much.